Well, welcome everybody. I'm glad to have all of you join us tonight for our final webinar of the year of 2021. We could not have made a better selection for this final webinar than our speaker who I will introduce in a minute. This webinar is being basically conducted on behalf of Northeast Ohio Liver Alliance. Northeast Ohio Liver Alliance is a new nonprofit that is founded in February of this year. The purpose of it is to educate our healthcare professionals and lay people about liver disease, to advocate for resources and policy changes and public health interventions that prevent and positively impact liver disease, and support research and public health interventions. Who are we? Who are our stakeholders? It's healthcare providers, those who have liver disease, their family, and the public at large. All funds raised by this organization will stay and support our local Ohio liver initiative. So we had a couple of three seminars before this one, and this is our final seminar of the year. I'm glad to introduce a friend and a mentor in Dr. William Carey. Dr. William Carey does not need introduction to our either local or national audience. I have two pictures of him. One is a recent picture, one slightly older, and I'll let him speak about that one. He probably doesn't realize I found that picture from probably late 70s when I had it, and he will tell me more about it, hopefully. He is currently a professor at Lerner College of Medicine. He was past president of the American College. He is a well-known hepatologist who mentored me and many others in the Cleveland area, along with my program director, Tony Tavel, who we named many events around him in the past. He will speak to us tonight about viral hepatitis, looking toward U.S. elimination. With him tonight is Erica Harrington, who is a pharmacist at the Cleveland Clinic, who is leading an initiative to eradicate in Ohio viral hepatitis, and she will tell us after he speaks to us about her initiative. Without further ado, I'm proud to introduce Dr. Bill Carey.
Well, thank you, Musa, very much for that kind introduction and for reminding me about who I used to be. So we'll see how that plays out. I'm going to get you back, you know. I remember you dancing in Syria, and I have some photos of that. Okay, so I'm going to get started by again welcoming the audience to the new Northeast Ohio Liver Alliance. We're very proud to get this program going, and we hope there'll be many more in 2022. I'm going to speak about elimination of viral hepatitis, particularly hepatitis B and C. And I'm going to talk about this at the sort of the 25,000 foot level. I'm going to be followed by Erica Harrington, who will really get a very granular presentation about what it's going to take locally to make this happen in Northeastern Ohio. So I think it's a good combination of topics, and we'll see how that goes. So a lot of this initiative comes from the World Health Organization, which many of you know is an arm of the United Nations. They're home based in Geneva, and they have declared that viral hepatitis is such a huge problem across the globe that considerable amount of effort, energy, resources needs to be devoted to it. For example, in 2013, it's the 7th leading cause of death. And 95% of the burden of these deaths comes from hepatitis B and C, so that will naturally be the focus of the efforts to eliminate these viruses from across the world. And you can see that there are bigger problems in countries other than North America, but there's plenty of hepatitis B and C in the US and in Ohio and in Northern Ohio, so a worthy topic. The World Health Organization has demonstrated that while many infectious diseases of great prevalence across the globe are decreasing in frequency, that of viral hepatitis is increasing. So all the more reason why efforts need to be made to reduce and perhaps even eliminate the 1.4 million deaths that are attributable to viral hepatitis across the world. So this slide is important. What's pictured in blue is the amount of acute liver failure that occurs from hepatitis A, B, C, and E. And what you'll see is that hepatitis C virtually never causes fulminant liver failure. Okay, so hepatitis C is kind of a stealth disease, and the active acute infection doesn't kill, but the sequelae of chronic hepatitis C, just like the sequelae of chronic hepatitis B, are what leads to the eventual development of cirrhosis, end-stage liver disease, liver cancer, and again, you can see startlingly high fatality rates over the course of a lifetime, particularly from hepatitis B and hepatitis C. So the goal, although the title of the World Health Organization announcements about this are elimination, what they're really calling for is an attempt to reduce by 90% the new cases of chronic hepatitis B and C, and a 65% reduction in the sequelae of chronic hepatitis B and C. So we're not really talking about disease elimination, but really a marked reduction in the community, and we'll see how that goes. So the World Health Organization has obviously studied this in great depth, and what they've come out with is a framework noting that there has to be a global strategy, and they, among others, set the agenda for this, but there also need to be regional action frameworks, national strategies or plans, and what I will add to this is what Erica is going to talk about later is local strategies and plans to make this possible. Okay, I'm going to say a word about hepatitis B. What is the problem with hepatitis B, and how can we eliminate it? So it's a threefold strategy. One is to prevent it through vaccination. The second is to interrupt vertical transmission, that is from mother to offspring. Around the world, that's far and away the most frequent way that hepatitis B is transmitted. And then to talk about treatment of infection, recognizing that if we accomplish just 1 and 2, there would be a generation of those chronically infected who will develop cirrhosis, liver cancer, and die from their disease. So we not only need to prevent it from occurring, but we need to treat the millions of people across the world who are infected. So I'm going to say a word about vaccination. I think most of us recognize that there's lots of limitations of vaccination, and this has been made very clear during the COVID-19 epidemic. We have lots of problems. And we have to recognize that for herd immunity, you really need the vast majority of the population protected. So that's a problem. Everybody's got to get on board. Okay, we need to recognize that when a immunization strategy becomes available, there are different responses to this. There are innovators, early adapters, early and late majorities, and laggards, and all of those, each of those requires a separate approach to get them on board, to get upwards towards 95% vaccination, right? And of course, we've seen writ large in the last 2 years, there are anti-vaxxers out there whom no one is likely to convince that they should behave otherwise. The other thing, of course, that's happened over the last decade or so is a general erosion of trust of authorities, including the authorities in public health and physicians for that matter. Okay. And then there's a group of individuals who just lack access. They might love to get vaccinated if they just had information and they had access to health care. So all of these represent problems, and here is an example of the problem as it relates to hepatitis B, okay? So we all know that for several generations now, we've had the ability to reduce almost to vanishingly small numbers the likelihood of contracting hepatitis B by a series of 3 immunizations, right? And here is the success rate, even among healthcare workers, it's less than 2/3 are actually vaccinated, have received all 3 doses, okay? And all the other groups are even lower likelihood of receiving their vaccination. So we have a job to do, not only among healthcare professionals, but everybody else. And here is part of the problem. There were several CDC centers around the country that were given extra boluses of money to try to get the immunization against hepatitis B up to speed in their local communities. And by definition, everybody received the first vaccination, so that would be 100%. But when you have to give a second one, you're down to 40%. And if you have to give 3 vaccinations, you're down to just over a fifth of the individuals who started out on the vaccination pathway got all 3 vaccinations. So if we're dealing with a vaccination that requires more than 1 shot, we're in trouble. And if it requires more than 2 shots, we're in even more trouble. And that leads then to the introduction a couple of years ago now, 3 years ago now, of a new vaccine, which really by this time should replace the 3 vaccination regimen. And that's based on evidence from these 3 pivotal trials, which were presented at the AASLD meeting just a few weeks ago. We can see that in every single trial, the 2 vaccination Hepatitis B was more immunogenic than the 3 vaccination Endurex vaccination strategy, and not by just a little bit, but by a lot. And if we look at various subgroups, we can see that in every subgroup, the vaccination was to the advantage of the Hepatitis B. And if we look at those with renal failure in detail, we can see a tremendous difference. 100% developed protective antibodies with 2 shots of Hepatitis B, and only 40% who got Endurex B. So a big difference. Big difference that we need to acknowledge. So I seem to have lost a little thing here. Let's see if we can get it back. So can you all see the slides?
Yes.
Yes.
Okay. I'm sorry, I don't know what happened. So we'll rough ahead and get to where we need to be. New immunization strategy should be Hepatitis B given twice, 1 month apart, and you'll be much more successful. Okay, a word about interruption of vertical transmission. That is, mother has it, she doesn't know she's infected, she gets pregnant, and she gives it to baby, okay, without any signs or symptoms. This is a big problem around the world, and how do we interrupt it? Well, we interrupt it by, first of all, testing all pregnant women. In the US, all pregnant women are tested for hepatitis B. And if mom has it, then the newborn should be immunized within 12 hours with both active and passive immunization. Okay, and the guideline says within 12 hours, but really, if it's less than 2 hours, that's much better. If mom has a high titer of hepatitis B in her blood, then she should be given a nucleoside analog to reduce the viral load, to reduce transmission to baby. And here is an article published a few years ago in the New England Journal of Medicine demonstrating that if mom has more than 200,000 IU per ml, and if she's given a nucleoside analog, she's much less likely to transmit hepatitis B to her offspring. So the guideline from the American Association for the Study of Liver Disease, administer a nucleoside analog in the 3rd trimester of pregnancy in pregnant women with a high viral load. And then finally, a word about treatment of infection. It is impossible to eradicate hepatitis B with infection, but it's certainly possible to suppress the drug, suppress the infection so that it's causing no liver inflammation and making the individual not contagious for others. There are at least 5 products. Yes.
Dr. Carey, I'm not seeing the slides progress, so I'm wondering if you're moving the slides or we're stuck on the same slide.
All right, well, it says I'm paused. Is that?
That means, Lori, can you help with that?
Oh, there we go. Now it's on which drug?
Well, okay, so what you all see is which drug, okay? All right, 5 approved products out there, but only 3 of them really are of any value. And now I'm having trouble advancing my slide.
If you click on the PowerPoint button on the bottom of your screen, that should bring that up so that you can advance. There we go.
But, all right, so the drugs that are worthy of mention are 3, entecavir and 2 different forms of tenofovir. Okay, each of them are very, very, very good, and it's kind of twiddly-dee, twiddly-dum for the most part. The differences between them are very small indeed. Okay, I'm going to pivot now to hepatitis C, talk a little bit about that. This is a very common problem around the world with 70 million people infected, and millions of people in the US are infected as well. You can see from this graph that the US is actually not one of the leading countries in terms of prevalence of hepatitis C, but we're right up there, and there's somewhere between 2 and 4 million people infected with hepatitis C. So how are we going to grapple with this? Well, first of all, we have to know whether an individual has hepatitis C, and the only realistic way to do that is to screen for it, okay? And if the overall prevalence in a population is greater than 0.1%, and that is the case in Ohio and in northeastern Ohio, all adults once in a lifetime screening, okay? And each pregnant woman should be screened during each pregnancy for the possible presence of hepatitis C. And then individuals at high risk should also be screened. And this is a little bit of a busy slide, but basically people who have injected drugs, who have received blood transfusions remotely, healthcare people who have had a sharps exposure, children born to mothers with HCV, and a few others that you can see in there. And then the last group of people who should be tested for hepatitis C is anybody who requests it. There's a lot of shy people out there who don't want to reveal what risk factors they have for acquisition of hepatitis C. And so the CDC guidelines call for testing anybody who requests testing, okay? And then the treatment choices in 2021, again, there aren't very many. They are really restricted these days to the kinds of drugs that will be effective against every hepatitis C genotype, of which there are 6, okay? And if we look at the pan-genotypic therapies, Epclusa was introduced in 2014, Mavorette in 2017, and then Vosevi in 2017 as well. Each of them highly effective. This just happens to be the effectiveness of the Mavorette, 98% cure rate. Virtually nobody stops due to side effects. 8 weeks of treatment if there's no cirrhosis, 12 weeks of treatment if there is cirrhosis. And the only major problem is the cost, $13,200 per month. Now, every insurance company is negotiating with manufacturers, so this cost may actually be lower by this point. But here we see the success rate of curing hepatitis C. These are in cirrhotic individuals. So these people got 12 weeks of treatment, and we're looking at Epclusa on the one hand, and we're looking at Mavorette on the other, and whichever you pick and whichever genotype you have, you see a very high success rate of viral elimination. So very excellent treatment. Because of cost competition, Gilead has formed a subsidiary to launch some generics of the Epclusa and Vosevi, and they've got their costs down as well. This slide, these costs were from a few years ago. I suspect the cost may be even lower today, but costly nevertheless. So what remains is not the development of the knowledge about screening or the availability of effective drugs, but among the things we need to pay attention to is expanding the pool of providers. If you have to send everybody to a gastroenterologist, infectious disease specialist, or a hepatologist, we're never going to get these people treated. So we need to expand the treatment arm. We need to let other people in. And there's been a very effective demonstration from New Mexico, published in the New England Journal of Medicine now 10 years ago, showing that hepatitis C treated outside of the major university clinic is just as effective as treated inside. So here we see success rate among rural primary care clinicians is just the same as it is in the clinic setting. And so there's no real reason why they have to be referred to a central treatment repository. So we also need national strategies, and what we can say is many strategies, including the US, have developed plans for the elimination of hepatitis B and hepatitis C. And every country comes at this a little bit differently. Here are two articles published a couple of years ago, one from Brazil, one from Australia, and each of them had a different take on how best to do it. So again, every country has to develop their own strategies, and Erica will talk more about the US strategy. So we have a global strategy, we have regional and national strategies, and I'm going to introduce in just a minute Erica, who will talk about a local strategy to eliminate, in particular, hepatitis C. So my conclusion is we really have the tools to achieve the World Health Organization a 90% reduction in new cases and a 65% reduction in people with advanced liver disease with hepatitis B and hepatitis C. And they're outlined on this slide. And again, on this slide, hepatitis B preventable through vaccination, large disease burden around the world, treatable but rarely curable. Hepatitis C, no vaccine, large disease burden, but it is curable in nearly everybody, and evolving strategies to treat all. So here we are. I think we're at the point where we can achieve success. And at this point, I'm going to stop, and I'm going to introduce I'm going to introduce Erica Harrington, who presented to our liver group a very exciting program that she and others are developing to help eradicate hepatitis C in northeastern Ohio.
Thank you, Dr. Carey. I really appreciate hearing what you had to say, and I appreciate the invitation to share the information that I have tonight. So this is kind of a newsy splash. Dr. Carey and I are speaking in regards to the same problem, but we didn't know what each other's slides were going to be. So I think mine are going to complement his very well and echo what he had to say. There is a problem. It's global. Depending on where you look, you're going to get slightly different numbers, but it's a global problem. But I really want to focus what's going on in the United States and what's going on in the state of Ohio. Here's what I'd like to cover really quickly tonight. I know we don't have too much time, but basically what I want to talk about is that local and statewide initiative called OH-HAMP, and we'll get to that here in just a moment. Reviewing the facts of the global problem, just as Dr. Carey said, there's people with hepatitis A, B, and C worldwide. The World Health Organization did target 2030 as the year that we were going to eliminate hepatitis B. We do have some countries that are on track to conquer that goal. However, there's two restrictions that the World Health Organization made to be excluded from that global list. And that was any country that still has treatment restrictions in place. Also, any country that's not treating at least 7% of their infected patients. The United States did not make that. So what is the goal? Just as Dr. Carey said, we're going to reduce new cases, we're going to reduce deaths, and we're going to diagnose this more. So that means universal screening. Here we have another surveillance report. Again, this kind of reporting does lag behind a little bit just because it takes them just over a year to put out that information. I show these slides because this was the change that the World Health Organization made for certain states. There's higher rates depending on what state we're looking at here. And if you notice the concentration here in the Midwest, the states of Kentucky, West Virginia, Indiana, Pennsylvania, Virginia, and Ohio, it's really a concentration of infected cases. And since that time, the World Health Organization did change Ohio's elimination target to 2050. Overlapping the problem is the opioid crisis. So we've all been watching the news of what's happening in West Virginia, what's happening in Kentucky, and that's Southern Ohio as well. So you can see that Ohio listed here is in the top 5 states of opioid overdoses and deaths. So review of the National Strategic Plan, and this does address prevention for hepatitis A, B, and C, and the roadmap to cure. I won't spend any time reviewing this. I think Dr. Carey did a very good job. So who's paid attention to this in the United States? There's lots of organizations nationwide trying to do something about it, trying to come up with a plan, either statewide or nationally. You can see AASLD and IDSA down there. Dr. Carey spoke of that ECHO program in New Mexico, which I'm familiar with. And the bottom one is really the one that caught my attention, and that's the US HAMP program. So some of the other states did get creative. Louisiana was a state in 2019. I remember driving to work one day and I heard on NPR on the radio talking about this Netflix model of treating hepatitis C. You don't hear that on the radio very often. It was very interesting. What they did is state Medicaid contacted a pharmaceutical company, contracted with them, said, hey, we want to treat all of our infected patients over the next 5 years. What will it cost us? So they estimated that they spent about $10,000 per patient. That was a very creative model because normally a state Medicaid can't contract prices directly with pharmaceutical companies. And that's close to the cost of what Dr. Carey referred to is the current cost of generic Epclusa is about $12,000, and it still is. So Louisiana did a little bit better with that, with the $10,000. The state of Washington went with the other pharmaceutical company, AbbVie, in July of 2019. They also drew in stakeholders, and they contracted out to treat theirs. Wasn't quite as successful, but they did something to try to cure the cause. Outside of the United States, countries got pretty creative as well. Portugal bought in bulk. Italy and Spain had their own negotiated contracts with the companies, about $9,000 per dose per treatment. I don't know if anyone knows about this one. In my research, getting ready for tonight, I came across this tour company for Egypt. Tour and Cure offers a 1-week stay full of blood tests and a 12-week course of Epclusa for about $7,000. So I thought that was pretty interesting. So here's that program. It's called US HAMP. This is a model that any state can adopt and make it their own. So remember that HAMP name. That's Hepatitis Academic Mentorship Program. And that's the model that I am creating for Ohio. So what is it? It's a collaborative learning network. And what it is just as Dr. Carey said, we're going to expand our pool of providers. The experts and specialists that we have, they're not enough of them. They can't treat all those patients. So we need to broaden the spectrum and allow more people to treat so many patients. Here's a little bit of the background. I'm going to tell you about the 2 states that are already up and running in this, and that's Kentucky and West Virginia. So US HAMP was inspired off the success of Kentucky. So Kentucky was the very first state. After they got off track, about a year and a half later, West Virginia started. This is kind of the leadership team. And how they approach the state is similar to how I am approaching the state, and we'll talk about that in a moment. So different from the ECHO program, this is more mentoring. So it's an 8-hour training program. I actually just spent today signed into West Virginia's training program, and it was about 10 hours listening to experts talk about different things, just like Dr. Carey did, treatment of HIV co-infected patients, treatment of cirrhotic patients. And what they do is all the other people on the call were primary care providers, OBGYNs, MAT treatments, people incarcerated, primary care providers that are interested in treating hepatitis C patients. So it's a one-on-one mentoring. After you attend the 8-hour program, there are 1-hour webinars to keep people educated, these primary care providers, and it would be guided under the experts. So these are the people I've been talking to. I did have phone calls with the Rural Health Primary Care Association. We have phone calls slated out for the State Health Department. We have had some phone calls with private payers, and state Medicaid will be the next ones. So what I'm doing today is coming to you all to talk about this local program, and I'm looking and open to people to join me in this endeavor and to join the academic faculty. So this is one opportunity that OH-HAMP can offer us is we use the REDCap system. The REDCap system was invented, created out of Vanderbilt University. West Virginia houses REDCap, and Ohio HAMP will be using that as a secure database so that you can track our outcomes. One question I get pretty frequently is, how am I going to get sponsorship? Who's paying for this? I have been in touch with US HAMP. They've offered money to get us going. And obviously the pharmaceutical companies have been very generous offering support as well. So Kentucky started in August of 2018. They trained over 350 primary care providers. They've processed over 1,500 referrals. A referral is a prescription written to treat a patient. They've tracked their cures. They have a 98.5% cure rate. And from that model, they created the U.S. foundational model. They thought, hey, if we can do this, why not make a model that anybody can adopt to use in their state? It took them almost 2 years to create their model. When West Virginia took their model and made it their own, it took them 3 months. So I've been working on Ohio HAMP for about 3 months, and I do have a kickoff date. One of the things that Kentucky addressed was removal of those treatment barriers. They only have 2 hepatologists in the entire state, so it was vital to them to be able to open up treatment to all these primary care providers. Their state Medicaid also eliminated fibrosis criteria, sobriety, and the drug testing requirements. Ohio has already done that, and I have heard that Ohio will be removing the specialist requirement in 2022. I don't know if it's January or more in the summer. So the Kentucky HAMP goals are the same that Ohio's will be. It will be to eliminate the number of people with hepatitis C, provide education to providers, and remove barriers to treatment. The CAMP program has been vital to helping me start this program. And then next I want to talk a little bit about West Virginia. I've already done all this Kentucky training, so that's under my belt. This is a diagram that's kind of important for people to scratch in their head thinking, how is she going to do this? How is the primary care provider going to be mentored to be able to treat a patient? So this already happens. If you use a specialty pharmacy, in effect, this diagram is already happening. So the consult form is the patient chart. That's your office notes when you see a patient. The consult form is the prescription. When you send that prescription to the specialty pharmacy, your prescription and your treatment plan gets previewed by a pharmacist before it gets sent to the insurance company. This formalizes that process. What West Virginia did after Kentucky is they put that consult form as an electronic form. It would be a web-based program, and you would have to fill in all the slots. So a primary care provider would be filling all the demographic information, all the required lab tests, and we'll be modeling our Ohio referral form off of Ohio Medicaid's form because that's the most inclusive one. If for some reason there's a problem with the prescription or the treatment plan, say a drug interaction or it's the wrong treatment length, what the expert faculty would do is they would kind of kick it back to the primary care provider to have that fixed, and then it would make that cycle again. Once it does hit the specialty pharmacy, it gets submitted to insurance, and then just like you're used to seeing, it gets dispensed to the patient. So again, there's your mentoring and collaboration, and that's what we're looking to do in Ohio. Here's the information about West Virginia. They started, again, about a year and a half after Kentucky in March of 2020. They replicated that US HAMP program. They've treated not as many. They haven't been around primary care providers as many as Kentucky did, but they did train over 361. They've processed 130 patients, and they have cure information. Same rate, 98.5% achieved cure. And again, they're using the the REDCap program to be able to track all that outcome data. So here's the logo for Ohio HAMP. This is a statewide initiative led by me with the support of Cleveland Clinic. I am open to everyone joining me in this initiative. It wouldn't be just a local thing, not just Northeast Ohio, but across the entire state. So here's a timeline of what's going on. Again, I started this about 3 months ago. Right now, tonight is broadcasting this information a little bit wider net. I hope you share this information with your colleagues, and we'll be providing information about how to get in touch with me if you're interested. Early in January and February, the program would be developed. So the program I'm speaking of would be that 8-hour day. I would need experts that would present their areas of expertise. I would be looking to schedule in that, and the launch date would be March 29th. So we're still identifying our key state leaders. I would be the champion for the state and be your contact for that. What you would do if you were interested in joining me on this effort is to attend a Kentucky or a West Virginia HAMP 1 event. I will have those dates available for 2022. They've already started scheduling those out. And then our kickoff for Ohio HAMP is March 29th, 2022. This is a virtual event. We won't be meeting anyone in person. Attached there is my email address, and that's harine3@ccf.org, and my phone number. I can come back to that slide if anyone needs to write that down. So here's my request to you. I'm hoping that you all are interested in joining me in this effort. I am building a leadership team. I'm building a website. I'd like providers to come and join me to present the Ohio HAMP sessions. The program will launch March 29th of next year. I'm looking for commitment for program development. So it would be what information is important to teach primary care providers to treat hepatitis B patients. Our best practice metrics would be that referral form. What are we looking for? What kind of input are we looking for from these primary care providers? If you were the expert that was going to review one of the prescriptions or treatment plans, what would you be looking for to make sure that that's an adequate treatment plan? I'm looking for faculty to be on the Ohio HAMP program, and I'm also looking to secure funding for the sessions. Right now, I'm planning 2 Ohio HAMP 1 sessions. Those would be full day. And then the second one, which would be about 6 months later, would be a half-day program. So I'll go back to this slide and open it up to questions.
Thank you very much, Erica, and thank you very much, Dr. Carey. Can you hear me?
I can, yes.
All right. I have a few questions, some from the audience, some from myself. Erica, did you say that we have less than 1%, less than 7% treated in the United States?
Yes. So thank you for the question. Ohio does not treat at least 7%. That's why we've fallen so far behind. I heard a statistic. It said for every patient that we treat with hepatitis C, 6 more are infected. So they're becoming infected at a faster rate than we can cure them. That's why the World Health Organization changed the state of Ohio to 2050.
So, I mean, as somebody who treats hepatitis C, it's much lower than I thought, actually. But nonetheless, my question to you, it's wonderful initiative that what you're doing. My concern is it focuses on the provider side, not the reach side. So we have a lot of people, as you said, addicts, prisoners, anybody who's high-risk population who we are not reaching. And by educating primary provider, there's an assumption that these patients will seek these providers. So the question is, if you want to eradicate something, you have to treat it at the site, in the prison, in the addict treatment centers. And so how can you address that?
That's a great question. So I had a couple of meetings. One of them was with AHEC, and that's the statewide meeting. I joined them a couple weeks ago, and I was speaking with one of the physicians there, and she works in a recovery resources facility. She treats hepatitis C patients, but she's not a liver expert. She just feels comfortable to do so. And what I learned from speaking with her is that patients don't feel comfortable a lot of times. There's taboo involved. I have hepatitis C. I don't really want to go talk to a different doctor. I only feel comfortable with this doctor. Patients that are involved in drug detoxing actually do better on treatment and have less reinfection rates. So it would be providing that level of comfort to the addict who's recovering from that or is interested in treatment, being treated right there where the patient's already being treated. They don't have to go to a different facility. They can go to their primary care provider right where they are.
But in terms of raising awareness, have you thought of using facilities like the DMV? So when you go in, you have a card that says, if you have hepatitis C, you contact this number. If you have places where almost everybody in Ohio will attend.
I haven't gotten that far in how I'm going to broadcast this out, but I'd be open to lots of ideas. I know universal testing is part of it. We have to test more people.
Another question, then I'll turn to Dr. Carey. So in terms of the initiative, you are focusing also on the cost, and successfully the programs that are sisters to this program succeeded in lowering the cost of the drug from the pharma companies. However, who covers that cost? So if I have no insurance and I went to a place and I found your number and I say I want to be treated, who covers me? Who pays for me? How do I send somebody who doesn't have insurance to HEMP?
So obviously this is a very, very important and good question, and I think the answer is going to vary depending on what group a person might be a member of. For example, if a person is a veteran, they ought to go to the VA hospital where treatment is rendered kind of willy-nilly without any particular barriers, okay? If you look closely at the World Health Organization, the cost that is going to be assumed to eliminate hepatitis B and C, the projected cost per person for hepatitis C is in the hundreds of dollars, not in the thousands of dollars. So we have a lot of work to do, there are some price reductions, but they're not nearly enough. I don't know if Erica has a better answer or an additional answer to that, but you're putting your finger on a real throttle point of this whole program.
Sure, I'd love to add something to that. We do get those referrals at Cleveland Clinic. I work at Cleveland Clinic Specialty Pharmacy, and we get prescriptions sent to us, and the patient doesn't have any active insurance. So we go ahead and reach out to the patient and get them signed up for a free drug program through the pharmaceutical companies. So whichever the treatment plan that was sent to us, whether that was Mavyret or Epclusa, that's the company that we contact. Previously, the companies for their free drug program would require the patient to not be eligible for insurance. And if you think about that, who's not eligible for insurance? Virtually everybody is. In marketplace availability, if they're not eligible for Medicaid, would be eligible to purchase it through marketplace. The only people that aren't eligible for insurance really is illegal aliens. So that was kind of a conundrum. We were assisting illegal aliens applying for free drug program when our residents of the United States weren't able to get it. So that's changed now. Fortunately, the pharmaceutical companies are much easier to grant that free drug application.
Could you just comment on how successful you are at getting coverage for a person who doesn't have insurance? What percent actually get treatment?
Every single patient. If they respond to us, if we reach out to them via email, phone calls, or whatever, we follow through with them. It's Cleveland Clinic, so I'm not sure other institutions what method they use, but we have a specialist in the pharmacy who manages all the free drug programs.
That's awesome. I would emphasize my comment about if 93% are not being treated, we certainly have not only to educate the providers, nurse practitioner, primary care, but somehow we have to reach these 93% and who are either not aware they have it or aware and they don't think they can be cured. So the other question is actually for Dr. Carey. Bill, if you mentioned how the vaccine is the way out from hepatitis B and there's no vaccine for hepatitis C. We all have lived through the magic of amazing scientific progression in inventing and really devising the COVID-19 vaccine in a short period of time, and which is an mRNA virus. Why have we not been able to do that for hepatitis C?
For hepatitis C, for hepatitis C.
Yes.
I do not know. I do not know. I mean, it's an RNA virus. I guess it shares some similarity to HIV, where we don't have an active vaccine either. But you're quite right. I mean, it seems to me if enough energy were put into it, there ought to be able to develop it. The other thing to say, of course, that everybody with hepatitis C has antibodies, right? We start with testing for antibodies, and those are not protective antibodies, right? They're there, but they are not protective. So the development of anti-HCV is not correlated with decreasing viral load or elimination of the virus. So there's something more than just the antibody that needs to be present.
Okay. Well, I think this is pretty much, I think, most of the questions that I wanted to cover tonight, and this probably conclude this wonderful webinar. We learned a lot from it, and I truly appreciate both Erica and Dr. Carey for doing this and educating the public and the physicians and other providers about this pandemic we have. We always talk about the current pandemic, but we forget that we have a very serious pandemic for many years with viral hepatitis that we need to eliminate. Thank you again, and I wonder if you have any final words, either of you, and if not, Bill, Erica.
Yeah, if I could, I'd just like to ask Erica, I mean, I know that you told us in some terms how we could help, but the Northeastern Ohio Liver Alliance is new. We don't have a lot of agenda things that are hot and up and running right now. It would be a very good time for you to tell us how we as an organization could help you and your team in the Northeast Ohio area. It's kind of exactly what we said we want to do as an organization. So we need your help to tell us specifically what would be most beneficial to you.
I'm coming back to the stakeholder slide. I invite you all to become stakeholders, become involved in the program, spread the word, tell everyone you know. I don't know where the slide is, this one. Become one of those people. So there's the academic faculty providers, become one of those. Send me an email, tell me that you'd like to present at one of the educational programs that we put out. The program Your Neola is out there to advocate, so let's advocate in both ways. So I invite you to become partners with us. I'm in conversations with the health department and the state payers, and I'm hoping to really kind of move mountains with this. So I invite you to join me.
Did you say you have a website that's about to launch?
I don't have it created yet. I actually just got the logo, so that's all happening. This was pretty whirlwind. When I got wind of this, I knew it was something, and so we started to adapt that US Camp program. So pretty young in this program. A lot's going to be happening in the next 3 months.
But we certainly should link to your website from our website.
Absolutely, Bill. And you have two directors of the board of directors with you tonight, and I think that will be a great asset to the community and to the Northeast Ohio Liver Alliance. We'll bring it in our board meeting, and we certainly would like to have close collaboration. I think that would be very helpful.
Oh, I thank you very much for that. I can send you my slides, Dr. Taba, and if you all can spread the word and join my efforts, I welcome that. Thank you very much.
That's awesome. Well, I think maybe since we have a couple of more minutes, are you aware of what is the most successful effort worldwide in terms of eradication? I know this, the state of Georgia, not the state of Georgia, the country of Georgia was one at one point, and France had been a big initiative. where does and what differs in these? I mean, I know, for example, in France, they got into the addiction spots and things like that. What experiences that they do internationally that you can draw from locally that not necessarily being done, whether by ECHO or by HAB or anything else in the United States?
Dr. Carey, do you have a comment on that first?
Yeah, from my research, it seems to me there are three countries that sort of stand out. One is Egypt, probably the most successful country in reducing hepatitis C burden. Another country is Morocco, and another is Australia. And all of them for slightly different reasons. In Egypt, the cost of treatment for hepatitis C is negligible. And I think Erica pointed out there's a medical tour you can take to Egypt to get treated for hepatitis C at a fraction of the cost it would be here. So that's one way of doing it. Australia has had a pattern of saying we're going to pay for everybody. Government's going to pay for everybody infected with hepatitis C, and they've negotiated a more attractive price with the pharmaceutical companies. So a lot of different strategies. I think we're a little bit hamstrung in the United States because insurance companies are not as willing to negotiate prices to a way low level. They'll give you some discount, but they really rely on sales in North America to fill their coffers and pay their shareholders.
The more difficult question, which comes in many other illnesses, Bill, is can we convince the pharma company to collaborate then rather than, I mean, can they make a concerted effort together with excellent drugs, whether it's Mayvert or Epclusa or anything else, rather than doing generic and say, we're going to partner with the government, local and state and what have you, and work on every spots and eradicate this, whether they divide geographic location, but make it so available that they're not competing, they are actually committed to eliminate the hepatitis C.
I would agree. I think the limitations here in the United States, and I don't have a clear understanding of it, is CMS. CMS guidelines do not allow states to negotiate drug prices, period. Louisiana did it, Washington did it, but they didn't do it very well. It was a nice try, but that's, to me, the biggest limitation.
So it's on the part of CMS more than, okay, all right. Well, I don't see any other questions. Again, would like to thank you very much for this presentation and wish you all happy holidays, and we'll see you next year. Thank you very much. This will conclude